few people coming. Looks like we get started. It's 8:02 Eastern Time.
Okay.
All right, welcome. So my name is Andrew Lithin. I'm a aerospace medicine resident physician at the Naval Medical Center, Portsmouth, Virginia, and the Naval Aerospace Medical Institute. Really glad to be able to moderate this event with SAFE, which stands for Scrubs Addressing the Firearms Epidemic. And you can learn more about SAFE and sign up for our monthly newsletter at www.standsafe.org. I served as a SAFE chapter leader while in medical school, and I'm currently on the National Board of Directors at SAFE. Now, for those of you new to SAFE, we're a national nonprofit organization composed of about 70 chapters at medical schools across the country, each run by a team of medical students, some nursing students, pre-medical college students at some of the chapters, as well as school faculty. SAFE is committed to all healthcare providers having the confidence and training to help their patients protect their families and overall protect their communities from firearm injury. And I think it's important to see where everyone is coming in from. So why don't you all put your state's abbreviation in the chat? If you served in the military, you can go ahead and put your service branch and years of service if you feel comfortable doing so. And thank you. I know some people are still at work on the West Coast. Some are at home. It's later in the evening. So regardless of where you are physically, I really do thank you for joining us today. In the middle of the work week. But just as a friendly reminder, I'd just like you to all make sure you're muted to avoid some background noise. Uh, and I'll go ahead and introduce our guests. All right, we've got a whole bunch of people here: Wisconsin, New Jersey, New Mexico, Texas, Army Combat Medic 0308, Michigan, California, Florida. All right, great. Okay, so to start off, I'm here with Dr. Dean Winslow. He's a professor of medicine and pediatrics at Stanford University, also a retired U.S. Air Force colonel. Dr. Winslow is one of the co-founders of SAFE, and he's an active member of the board of directors at SAFE. I'm also joined by Dr. Kyleanne Hunter, CEO of Iraq and Afghanistan Veterans of America, or IAVA. Dr. Hunter is also the newest member of SAFE's National Advisory Board. She's a retired naval aviator flying helicopters in the U.S. Marine Corps. She's testified before Congress numerous times, and she serves as a wonderful advocate and partner to veterans in all of her impressive roles professionally and personally. So SAFE is really proud to partner with IAVA to host this event. IAVA's mission is to increase awareness in the media among the American public and in Washington, D.C. to ensure that the voices of our newest generation of veterans are heard and listened to. SAFE really does look forward to this new partnership and is really grateful to IAVA and Dr. Hunter for being with us tonight. So, Dr. Hunter, Dr. Winslow's discussion will be followed by a Q&A, and this will overall discussion will range from firearm ownership and risk for veterans, suicide prevention, secure storage, and firearms safes and locks. We'd like to give our audience the opportunity to submit questions in the chat, and we'll go ahead and have Allison Volkman, our executive director, keep an eye out for this. And towards the end, we'll start pulling these questions and start answering them. So to start off, Dr. Winslow, before we meet Dr. Hunter, can you please briefly share a little bit about how you came to begin working on the subject of firearm injury prevention before you founded SAFE?
Yeah, absolutely. So again, I actually grew up, in a family we did not own guns, but I went into the military, pretty early in my life, and of course, obviously qualified many times, with both the 30 initially the 38 caliber pistol and the 9 millimeter, and then of course, the M4 and the M16 automatic rifles during my career. And again, we carried these weapons routinely, particularly outside the wire, when we were on combat deployments in Iraq and Afghanistan. One of the things, though, of course, that just broke my heart was just seeing, though, the toll of casualties, both, from our enemies, of course, as well as sadly suicides, even in theater. And one of the things that, of course, also as a father and grandfather myself, that really upset me was the number of mass shootings in the U.S., most of which were committed by, civilians who probably, in retrospect, really should not have been allowed to buy or own an assault weapon, using those, to kill, in many cases, dozens of human beings. And so I think, we really saw this as a true unmet need. And, the fact that right now, that firearms are actually the leading cause of death of children, less than 18 years of age. To me, again, as someone who takes care of both adults and children, is really upsetting. So I think the more that we can do to educate doctors and other healthcare providers about how to reduce the risk of firearms deaths in our patients, I think is, it's worthwhile.
Yeah, I couldn't agree more. Firearm ownership, the culture around firearms is really ingrained in military culture. So
Mhm.
that's why I'm really glad that we can bring on Dr. Hunter. And thank you again for joining us. I gave you a brief introduction at the beginning of the event, but I'm hoping that you can share a little bit more about IAVA, yourself, and what made you focus on firearm injury prevention.
Absolutely. And thank you so much for having me here. It is also wonderful to see so many friendly faces and names from IAVA, from my Brady days, from folks I've got to meet through Dean. So this feels like a great sort of homecoming of sorts to be on here. And so I'm gonna start actually answering your question in the opposite direction and talk a little bit about how I got involved with gun violence and then really where it fits into IAVA's mission. So you mentioned Marine Corps aviator. I was a Cobra pilot, which was an attack pilot. I was part of both battles of Fallujah, which for those who are familiar with recent Marine Corps history, well, it was over 20 years ago now, so I don't know if we call it recent anymore at this point, dating myself. It was one of the deadliest times for Marines that we've had I mean, that we had in all of the global war on terror, but even, deadlier than some of the horrific battles in Vietnam and going back into World War II. And I have very distinct memories in Fallujah in 2006 of the Marine Corps saying, we need to take a pause and figure out what's going on because there is way too much loss of life that is happening right now. And we are in a active war zone, right? And this was over the course of weeks. There were hundreds of deaths and hundreds more injuries that happened. And fast forward a little more than a decade after my time in Fallujah, there was the mass shooting at the Harvest Festival in Vegas, for those that remember that very, very tragic event. And the death and injury toll for that were almost exactly the same as what we saw in Fallujah in terms of the numbers of people who were killed and injured, and that was in a matter of minutes, really, that this happened. And with the response being almost a little bit of a shrug of the shoulders of like, well, there's really not that much we can do, right? There's a beginning sort of thoughts and prayers conversation that happens, but there wasn't any real action. And that for me made it very, very clear that veterans have a very, very important role in having meaningful, pragmatic conversations about gun violence prevention. I am a lifelong gun owner. I've been around guns my entire life. I grew up hunting. I competed in shooting sports quite a bit. I still am a gun owner, and I think I will disclose that up front and
Yeah.
personally here that it's been a part of my life. But I think we need to have gun owners, and especially those of us who have really been around the deadliest ends of weapons and have used them in that regard to carry the water that gun violence is unacceptable. And
Mhm.
then as I became more involved in the veteran space, it is very, very clear that the leading driver of suicide for veterans is firearm access. The vast majority of suicides take place with firearms. It is part of the conversation that has to happen. We can't talk about suicide prevention without talking about firearms. And we know that things like safe storage works. We know that
Mhm.
policies that make it easier for people to do the right things and protect themselves are life-saving. So at IAVA, as part of our broader suicide prevention engagement, our members are very clear that this shouldn't be a partisan issue, that safe storage, having real, meaningful, pragmatic conversations about the risk that firearms pose is an essential and life-saving part of our suicide prevention mission. And so, in addition to advocating for some of the legislation, some recent Saving Our Veterans Lives, being able to have conversations like this as to how the veteran voice fits in, how we can save veterans' lives, and how we can move the narrative forward to save the lives of civilians here in America as well is something that is incredibly important to our membership as well as incredibly personally important to me.
Yeah, wow. I mean, it's what you do. There's so much to it. And given that there's so much politics that's binding it all up, it can almost seem like there's a level of futility that you can't get past. I mean, what core beliefs do you really hold as a veteran, as a gun owner, veteran that really helps you navigate these types of difficult interactions, and really push the message forward?
Absolutely. And I think I also want to give a huge shout out to IAVA members who do this so well. And I think there are three real big pillars in terms of core values. One, I can go back to, and I'm going to use three for my first one. I'm an academic. I get to make up my own rules in terms of counting, right? So,
That's right.
we get to make it right. The first is a real adherence to the values that I grew up with as a Marine, right? Honor, courage, and commitment. That this is having these hard conversations, honor my friends who have died. And I think I'm at this point, and I know Dean and I have had so many of these conversations that we've lost more friends now to suicide since we've been home than we have downrange. And so to honor them is to do this hard work. Um, the next is the courage piece of this, right? The fact that it is not easy to have these conversations. They're not necessarily fun to have. They can become combative, they can become contentious, they get hyper emotionalized. But, as veterans, we have an obligation to continue to be courageous and to live courageously and to do the hard things. And so that is another like real part of this. And then it's commitment, which is seeing it through. I'm heartened to see so many folks that I've known through various facets of the way that I've worked in this career who know that this is a long game, right? This is commitment. This is something we need to really pull forward. Next is a real dedication to evidence-based advocacy. Uh, I became an academic because I believed in the need, or I would say I went and got my doctorate. I have never actually been an academic. I've been an advocate my entire life in this space, right? But I went and got my doctorate because I believe there needs to be evidence-based advocacy, that laws and policies work when they are grounded and rooted in facts, not emotion. There's so much emotion that can get wrapped up in these hard things. And so holding it back down to this is the evidence that will save lives is essential because you can cut through so much of the noise, right? You can have those harder conversations if you stay rooted in evidence-based advocacy. That is absolutely essential. And third, in terms of like the core beliefs in this is a real commitment, and I may sound starry-eyed and idealistic here, but back to the fact that so many of us here swore an oath to a constitution that is a democracy where it is about having the messy, hard conversations and a government that ensures life, liberty, and the pursuit of happiness. And if we are continuing to live under the threat of gun violence, whether it is from suicide or mass shootings or whatever it is, we don't have the ability to actually adhere to life, liberty, and the pursuit of happiness.
Okay.
Yeah,
Yeah.
yeah, well said.
Yeah. I mean, it's heavy work that you do. What do you how do you stay sane doing it? How do you deal with that mental and physical toll, addressing all of this?
I mean, like as Dean and I joke, we make sure we do 57 push-ups a day at this point now in our times. Physical fitness is important is an important piece of it. But
Mhm.
I think even just we and again, I'll go back to my data-driven side of this that like there are tons of studies that show that having those healthy practices of physical fitness both keep the mind sharper and help you navigate through this. But to pull it back and actually speak a little more seriously about this topic, it is community that is very, very important. It is finding common ground. It's having conversations like this that is essential to find the way through it because much like when we all served together, we had each other's back, right? If someone had to pick up the load because you were tired, you were able to pass the baton on. So it's building networks and building communities and ensuring that we can continue to have a community of advocates for this work because it is hard, right? And I think everyone who has done this knows that it's hard and knows that it's part of the long game and knows that there's a time when we really do have to rely on each other to make it work.
Yeah. Wow. And it's your work really comes to light here, especially recently. We had the Sergeant Major of the Marine Corps, Sergeant Major Ruiz, top enlisted leader of the Marines, just last week posted online urging Marines to ask for help if they feel that they're in crisis or approaching it, emphasizing that risk of suicide by firearm specifically. So can you talk about a little bit more into the numbers, quantifying that risk of suicide, self-harm in our military and veteran populations specifically?
Absolutely. So when we look
Yeah.
at the numbers and where things are, it's a unfortunately bleak picture. I think if we look at, and there just very recently was the new suicide report that came out, and while the overarching number or the number of suicides reduced, the prevalence rate went up, right? And that largely the number went down because the veteran population just keeps getting smaller and smaller, but that's still that rate per
Mhm.
100,000 continues to go
Yeah.
up. So it's somewhere between 17 and 22 veterans a day die by suicide, and the numbers depend on sort of how these are counted. One of the big concerns we have with some of the VA data is that it really relies on people who have already been in the VA system, and we know that
Mhm.
the majority of veterans who die by suicide have not been connected to the VA system, and so there's prevalence rates put it higher than what the VA's official estimate actually is. Um, but if we look at this, the vast majority of these firearm or these suicides are because of firearms, and this poses a real unique risk because firearms are the deadliest method of suicide attempts, and we know that by and large, people who attempt suicide and survive very rarely go on to attempt suicide again, right? Or those who have a barrier put between them and the firearm. The idea of means substitution is something that doesn't happen very rarely, right? People who survive a suicide attempt, close to 90% of them never attempt suicide again, right? It was a acute moment that really drove a suicidal crisis. And
Mhm.
Dean has, I know,
Yeah.
has real familiarity with this. And then finally,
Mhm.
before I want to kick it over to Dean to really talk about some of this
Mhm.
acute risk that veterans face, is that women veterans are at a very, very unique risk. And it's gotten bleak that these numbers have gotten worse. Compared to age matched civilians, women veterans are almost twice as likely to die by suicide. And they don't have higher rates of diagnosed mental illnesses than their civilian counterparts. They may have different issues, right? But they don't necessarily have higher risks. And it all comes down to access to unlocked guns, right? That is much more likely that a woman veteran has access to and is comfortable with a gun in her home than a woman civilian is. And that alone really drives and almost doubles the risk of death during a suicidal episode. But I do want to kick it over to Dean on this a little bit to
Mhm.
talk a little bit more about some of the myths and really the acute nature that is unique to the military and veteran population, that these aren't people who are necessarily struggling with long-term mental health conditions.
Mhm. Yeah, absolutely, Kyleanne. And again, just a little bit about my own, personal experience. So I graduated from medical school almost 50 years ago, and I was just 23 when I graduated, and I had actually, started out kind of in the civilian world. I wasn't commissioned until 1980, and you know, so one of the things that we were actually taught in medical school, was that most people that attempted or committed suicide, had a history of long-standing depression. That was kind of what we were taught. And, I think up until recently, that's probably still, kind of the dogma. Again, what I saw, as an internal medicine resident and, young doctor in practice, kind of reinforced that to some extent. But again, these were 100% civilians. One of the things that just absolutely just was devastating. Again, I deployed 6 times to Iraq and Afghanistan after 9/11. Was my 2 tours actually as the hospital commander of our EMED squadron in Baghdad in '06 and '08. And it just was absolutely shocking. I probably during those deployments pronounced at least 6 to 8 people who actually committed suicide with their weapon downrange. And none of these folks, had, a documented history of any kind of mental health issues. However, one of the things that we did see in common was like almost all of these folks had just received a letter from like either a husband or a wife or another partner, basically breaking up with them, what we used to call a Dear John or a Dear Jane letter. And the fact, though, that we actually were required, to have a loaded weapon with us when we were downrange, it just made it way too easy to commit suicide. And again, I kind of was joking when we had a preliminary call a couple days ago that if let's say you're back in the States and your girlfriend breaks up with you or your boyfriend breaks up with you, well, what you might do is like call one of your buddies up, and go out and say, hey, I need to talk. Let's go get a drink and then by the end of the night, whatever thoughts you may have had about suicide were probably gone. But the fact is, though, that if you put a loaded gun, to your chin and pull the trigger and blow your brains out, there's no going back. It's not like, taking an overdose of pills, where there's a very good chance that, someone will find you, you'll be brought to an emergency room, your stomach will be pumped, and you'll survive just fine. But as I said, though, that the decision often to commit suicide is very, very impulsive. And the fact is, though, sadly, that that you really it's irreversible, basically if you blow your brains out. And so I think that's, kind of the stakes that we're dealing with here. And so, I'm just like totally committed to, if we can save the life of even a handful of veterans every year from suicide, it'll be worth it. All of our efforts will be worth it.
Yeah, I mean these are some really incredible points
Mhm.
that ought to be emphasized, and we've got a post 9/11 veteran population spanning
Mhm.
multiple generational cohorts.
Mhm.
I mean, cultural, demographic, socioeconomic backgrounds that just vary wildly.
Mhm.
In my own experience, we've got grief, family dynamics, coping skills, and dealing with stress. Just all across the spectrum. So we discussed encouraging communities,
Mhm.
veteran populations to reach out and ask for help, but exploring, I guess, more so preemptive measures, identifying risk before a
Mhm.
crisis emerge. You talked a little bit about this, with a Dear John letter, a particular incident.
Mhm.
But in the moment behaviors, life events in the military, transitioning to civilian life, these big transitions, maybe also later in life, physical health changes. Can you talk a little bit more about that? I
Yeah,
just
and
move on.
yeah. So again, Kyleanne and I, talked about this, briefly on the call with you the other day.
Yeah.
But again, that I think there are also some of these, stresses and experiences are cumulative. So I think a lot of us, particularly that served outside of the wire, in Iraq and Afghanistan, we saw some horrible things that you can't just erase from your memory. And again, actually in the kind of the post-Vietnam generation, we actually started, we put a name to it. We called it PTSD or post, traumatic stress disorder. Again, that's a, fancy sounding name, but it's very real. However, on top of these memories that none of us can erase, that
Hmm.
we're downrange, there's also, the fact that, as you get older, particularly after you take the uniform off for the last time, that I think a lot of us, like lose this sense of purpose, in our lives. And again, that's one further thing that I think it just makes it so much easier, for a veteran to commit suicide. And so I think, these are some of the things that that affect, veterans maybe more acutely, than our civilian cohorts. Kyleanne, I'd be interested in kind of what your perspective is on that.
Yeah, and I think one of the things, Andrew, and you mentioned this that I think is really important
Mhm,
is when I look at across sort of the data about those who served in Iraq and Afghanistan, we have people ranging in age from 23 to early 80s.
mhm,
And which makes it also very difficult to try to often find what is sort of that one root cause driver of
mhm,
suicidality or how to approach even how to approach
mhm,
safe storage conversations, right? To bring it back to these
mhm,
conversations around the connection between firearms
mhm,
and suicide is that if you're having a conversation with someone in their early 20s about
mhm,
risk factors, they are very different than if you're having a conversation with someone in their 70s or 80s about risk factors because of what either the main drivers might be, right? As Dean mentioned, there's often this like acute thing that happens, but when we start
mhm,
talking about identity change,
mhm,
there's a really significant you a really significant amount of work that really still needs to be done in that regard because
mhm,
we haven't had a generation of veterans who did multiple back-to-back deployments the way that this generation did.
yeah,
And then, often they came back from six, seven, eight, nine deployments was not actually that uncommon, right? For those of us that were
mhm,
in, like especially in the early side of the aughts, and then we came home and we jumped right back into life, whatever that was. And so as people are starting to now age out of the workforce and maybe they have kids that have gone up and like grown and they're really discovering who they are for the first time, we
mhm,
have to do a lot of work on understanding how does identity and suicidality really relate, and
mhm,
how is that different from our generation of veteran. We also have a generation of veteran where women are the fastest growing group of veterans, and we have virtually no research on
mhm,
specific suicidality, almost none on how menopause and mental health
mhm,
intersect and what that might mean for suicidality. We are missing a significant amount of research on the LGBTQ community, especially as they age, and how the intersection of military service and other forms of identity, right? Where that really intersectional pieces and what that might mean for suicide and suicidality. And then, finally, in terms about, I think, just unique aspects of our generation of veterans, is there's a lot of work that still needs to be done on the intersections of mental and physical health and how they relate together. We have of people who had any sort of physical injury in Iraq and Afghanistan, more than three-quarters of them were also sustained some sort of blast experience, right? Some subconcussive blast experience. And we didn't have a protocol for what that meant, right? If it wasn't a full-blown TBI, right? We didn't really have a good protocol. And we sent people as soon as they were patched back up, from whatever their injury was, right back down range. And we don't know as people are aging what the intersectional impacts might be and what that means for suicidality. So I think it's also a conversation of so much more research because our post 9/11 generation of veteran is so unique, so diverse, and has had really unique experiences that coincide with huge changes in medical advancements as well. And so I know I sort of veered us off topic a little bit there, but I think it's important to
good
talk
points.
with this group who really want to understand, I think, some of the research and where the gaps are too.
Yeah, no, I think that's an excellent point, and I think that's also a really great segue for me just to remind everybody. Feel free to post questions in the chat. We'll go ahead in a few moments, review all those and start answering them. But really, really a great conversation. Shared experiences amongst veterans can result in, I mean, just massive amounts of grief and anger and how these emotions can manifest over time. How do you guys make room for compassion and empathy to come through all of this?
I mean, I can start with this one, and it's actually really interesting. I was having a conversation with another Marine who now works in like the big fancy corporate world and like a Fortune 50 type company running a
Yeah.
Dean and I somehow we end up running in a lot of those circles. I think now we're in the Bay Area.
Yeah.
There's a lot of folks there, but
Yeah. Not that we're proud of that though.
no, but it's there. But he runs the military and veterans program, right? Not the ERG, but the actual hiring, promotion, work and program. And we were talking about the fact that during people talk a lot about war as being this like fast-paced thing, actually, right? But the
Yeah.
a good chunk of your time deployed is downtime, right? There's a lot of nothing, it is 70% of nothing punctuated by multiple 30% episodes of like all out, right? But
Yeah.
so because
Yeah.
of that, you actually build these interesting senses of community while
Mhm.
you are downrange because you have nobody but each other to engage with, right? So the
Mhm.
amount of card games that get played, or there's always people with like it's very stereotypical, but you see people sitting around smoking cigars out like in a
Mhm.
smoke pit, right? Or like puzzles became a popular thing, right? Like there are things to do
Mhm.
that are low tech. 'Cause it's not like we were, or at least, as a Marine, we didn't have the fancy Air Force, Gucci TVs everywhere that we would, right?
Yeah.
But it created this sense of when we were downrange,
Mhm.
actually like space to almost emotionally debrief after things,
Yeah.
just sort of by proxy, right? It wasn't intended. It's not like we were like, oh, let's all sit
Mhm.
around and like talk about our feelings, but you're after whatever it was, and everyone's winding down, sitting around and playing
Mhm.
cards, right? Like that becomes a thing that starts to create space for this shared
Yeah.
grief, shared compassion, shared space. And we were
Mhm.
only around each other, right? We knew we had all done it.
Mhm.
And when we get home, we scatter to the winds, right?
Mhm.
Completely
Yep.
just scatter to the winds, right? Even if you are still live near a base, because you get back from deployment and you're like, the last thing you want to do is be around these people anymore, right? You're like, good riddance, you smell, literally, right? Like, you want to run away and like go take a
Yeah.
shower and never be around you again, right? So you lose that space, and I think it builds hardening as a defense mechanism, right, from the rest of the world, really from the civilian side of the world. And I think it is about finding spaces where veterans can be back together again that are really, really important here. Because I think when you
Yeah.
put things together, compassion and empathy is
Mhm.
is huge, right? Because we've
Mhm.
all watched too many people die, but we don't have a very good mechanisms often to keep those connective tissue points, right? Which is why, I'll make some plug of like the importance of like doing joint advocacy work together because you
Mhm.
can build some of that same like social bonds that then have like up times and down times together to build that compassion space.
Mhm.
Dean,
Yeah.
interested in your thoughts on this too.
Yeah, no, no, exactly. You really hit the nail on the head. And, I used to, like tell people, like, in a way, like being deployed downrange,
Yep.
was less stressful in some ways, than being, back CONUS, where, depending on your job, you got multiple responsibilities and committee assignments, plus, you're a mother or father. on top of it and everything. Whereas downrange, you just have one job that you're doing, and that's fly combat or take care of combat casualties or whatever. And again, the downtimes that we definitely had, between, incredibly scary and, the experiences were really meaningful. Again, I remember so many times like, you know, sitting, let's say, on the roof of a Connex, in the sun in Iraq as it's setting behind us and looking out over Baghdad and, drinking non-alcoholic beers, with my fellow airmen, and solving all the world's problems and talking about that. Whereas, we don't really have that, back in the States, and certainly, not with people that, that shared those experiences with us. And I think that's a really good point that you made, Kylan.
Yeah, yeah, and I guess I have a follow-up question for you, Dr. Winslow. So, now, as a physician, what's a good way that you could almost introduce this sense of community, shared grief
Hmm.
in healthcare to better support our veterans? I mean,
Yeah.
they come
Well,
back home and you've got them juggling all of these different roles,
mhm,
from being like yourself, a father, a
mhm,
husband, a doctor, a teacher,
mhm,
um, where you didn't just have, oh, I'm a doctor, I'm in the military, I'm working. Now I'm back home, I've got all these other responsibilities. What's a good way to
mhm,
kind of take a step back for these people and have them, really
mhm.
feel like they've got that support?
Yeah, I think it's really, really tough, and I'd be interested, kind of in Kylan's,
Yeah.
thought about it. I think it's actually, potentially easier in some communities, like let's say, like no kidding, if you live, in rural North Carolina, not too far, from one of the military bases where you have large numbers of retirees, the American Legion, and although, sometimes it's not great because a lot of it revolves around, drinking in the bar, but but still, though, you've got those communities. I think in a way it's harder in a place like the Bay Area, where there's just such a tiny, tiny number or percentage, certainly, of military veterans, particularly those, who did serve, kind of in the intense ways that, people like Kyle Ann and myself did. So
Hmm.
Can I
And
can I comment? My name is Guy McDermott.
yeah,
I was invited by Thomas Keener. I'm a commander of one of the VFWs here in Solana Beach.
yeah.
Yeah. And
So,
this is a great question, and I think this is actually a really important topic because it's not about the guns. It's more about the mindset of these men and women
hmm
as they come out of and transition out of service.
hmm
And so where what I'm attempting to do, also a co-founder of Project Restore Hope, is to create
hmm
that safe environment and that safe house for these men and women to actually be held and seen with
hmm
compassion, right? Because
yeah.
a lot of us were forged in fire from a very young age. We
Mhm.
become warriors because of what we deal with when we're young, and then we step in. I'm a retired SEAL, and what I dealt with as a little boy was set me up for to be that warrior that I was.
Mhm.
But
Mhm.
how do I unravel that? How do I get through that? And what
Mhm.
we're seeing there at the VFW, we're not a bar, we're not a canteen,
Mhm.
is that we are creating a safe place or a safe house
Mhm.
for some of this trauma and energy that is built up inside of us to be
Mhm.
let out,
Yeah.
to be seen for that, and to be held with more of a space of compassion and love.
Mhm.
And a lot of what we're doing is holding space for others, and a lot of peer
Mhm.
support is part of
Yeah.
this. And I think that really warriors can understand the plight of another warrior. Dean, as you were saying, it's like
Mhm.
we understand each other. We understand what we've gone through, and in that process, we can hold that space to let that whatever that is
Mhm.
out. And when I what I realized is it wasn't what the effects of combat or being a first responder. It was the effects of what I dealt with when I was little and how then I had adaptive and maladaptive behavior
Yeah.
to deal with that.
Yeah. That's
So
well said, Tom. It's really, really, it's great. Thank you, by the way, for the great work you're doing. Appreciate it.
All right. And then, Dr. Hunter, what would you like to add? I know you take somewhat of a alternate approach as well with some of the policies and legislation, but I'd like to get your input as to what healthcare professionals, doctors, can do to better support veterans.
So I think there's again a three. I'll use my academic rule of three
Yeah.
and everything here too. One is to this is going to sound very basic, but it's very, very important, is to ask everyone who comes into your doors if you are a veteran. And this is
Yeah.
a incredibly, incredibly important because you don't know by looking at someone if they are a veteran or not. There's often a very stereotypical idea of like, this is what a veteran looks like, right? And I think you look at the three of us and the gentleman who's just pulled on camera too, we all look different, right? We all are very different looking and you don't know, right? And I will again do a great academic thing and plug myself. Myself and Kate Hendricks Thomas wrote a book called Invisible Veterans, which focuses on the transition time for women, right? Where women go from being the most visible service member to the most invisible veterans. And it's not just an anecdotal side, but in the survey data that we've done at IAVA and the work that I did at RAND before I came to IAVA,
Yep.
nearly three-quarters of women veterans never get asked if they are veterans when they go to
Yeah.
civilian providers, right? So number one thing you can do to build community is just ask and start to see people for who
Mhm.
they are, right? Don't make assumptions about what a veteran is or isn't. Next is I think that there's a real opportunity for healthcare professionals to be able to have like honest and blunt conversations with veterans about hard topics. One of the things, there's a conversation about being forged in fire, right? But there's another piece of it is that as a member of the military, we do risky things all the time, right? Our military service is built around
Mhm.
risk and mitigating risk and having hard conversations about what are the hard, risky things you're going to do, right? When I was flying Cobras, we had ORM conversations every day, operational risk management conversations
Yeah.
every single day as to like, are you safe to actually fly? And because flying an attack helicopter is inherently a risky activity. And so we need to mitigate it. And I think there's a way for you healthcare professionals to have these hard conversations with veterans and just put it in the frame of like, you're going to do risky things. That fine, right? Firearms themselves are risky. It doesn't mean don't be around them. It means
Mhm.
be smart, right? And we can handle it. We don't need to be handled with kid gloves in those conversations, right? You can have them blunt and honestly. And then third, and it was alluded to a little bit right before we got on this, was actually get to know the holistic picture of your patient. This is something that the VA actually does very, very well in terms of creating a sort of whole of person approach to care, but it is often not the combat trauma that drives issues. We know that members of the military are much more likely to have had adverse childhood experiences, often called ACEs, to get all academic here, right? That's a lot of the reason people join the military and actually can be very successful. So it's understanding that. For women, when you talk about where mental health concerns come up, it's 4 or 5 times more likely to be from military sexual trauma than it is from or childhood sexual trauma than it is from anything combat related is actually like the driving factor between things. And so I think it's also not seeing veterans as one dimensional. So ask if you are a veteran, have conversations, and realize that we have multifaceted drivers and are very intersectional as people, right? That may lead to where trauma or stress holds itself.
Uh, I love it. Yeah. I mean, I think this is great. In my own experience, helping triage people in the emergency room at the Naval Hospital here, and we ask the tough questions, but we ask them at that moment of crisis. And I think it's really
Mhm.
important to start asking those questions way in advance. Help identify, okay, let's get you some help before it becomes a crisis. So,
It's also when you talk about so often, sorry to jump in and
Oh
interrupt you,
Yeah.
yeah,
it's so often put on like trauma surgeons to have this conversation, right?
yeah,
Pediatricians should be having these conversations with parents, right? Just getting to know
Mhm.
them, right? Your orthopedic surgeon, if you're an orthopedic surgeon, you should be having these types of conversations, right? You're a radiologist, right? There are normalizing having conversations about risk mitigation, safe behaviors, all of that across the board because, what the data often show us is that it's usually not the trauma where someone's at their greatest risk. It is in those routine visits and those continued routine visits where you learn behavior. Also, just from like a psychosocial aspect, you can talk to someone when they're at a moment of crisis and trauma, but they're not going to absorb very much of what you're talking about, right? You can remove them from a very acute risk situation. And is it important if someone is in imminent risk, whether that is of suicide or homicide or imminent partner violence, whatever it is, right? If someone is at a moment of acute risk, we do need to remove them from that moment of acute risk.
Yeah.
But behavior change doesn't come from what you are told in a moment of acute risk. Behavior change and actually understanding people and where you might see changes in behavior and identifying signs and signals in people come from the interactions in more routine settings, right? And things that are be more like normal well visits with your kids, right? That you are in a more routine side, right? A routine physical type thing, right? So it's often normalizing these conversations, not just when you have someone who's in crisis or trauma or in a unsafe situation, but starting to have them. And it's the same way we go back to this veteran communication, right? Like it's the same way we train, right? We first have to learn how to do a new behavior in a controlled environment before
Mhm.
you're thrown into a traumatic, chaotic environment to do it well.
yeah. No, I love it, and I mean it's pretty simple when you're asking about, hey, are your kids wearing life jackets when they're going out playing in the pool or whatever, or out in the lake? You could just throw right in. Okay, let's talk about how you store your guns. So I think that's excellent. Well, we've got a whole bunch of questions from the chat that really go along well with what we're talking about. Let me start pulling some of them, and I'll have both of you guys weigh in. Um, we've got a question from Tom K. Are red flag laws part of a solution? What would you guys say?
So they can be, right? Like this is like any
Hmm.
laws and policies that exist, they're as good as they are funded, enforced, and educated about, right? I think if you look at so for those that aren't familiar, red flag laws or gun violence restraining order laws are laws that allow firearms to be temporarily removed
Mhm.
from someone in crisis. And there's a variety of ways that they show up. I'm not going to go into every single model of them, but they are temporary, and you can get them back. Is the end of it? Like if they are properly resourced and those that are involved with them, whether it is through the law enforcement system or through the courts or through other third parties that can act as providers, they need to be educated, resourced correctly, and the community needs to be educated on them, right? Because they work if people trust the system to use them and trust that they are not actually a violation of rights. If they are, so they absolutely can be part of the solution when they're done very, very well. I think it was like, I believe it was the study out of Connecticut that has some of the best ones that you've actually saw a large reduction of suicide because of these, because they were done very, very well. Colorado has some very good ones that are
Mhm.
modeled after, right? So, like any law and policy, they work very, very well when they are resourced appropriately, and people are appropriately educated on what they are and how to use them.
Okay. All right. My and I guess for Dr. Winslow to follow up on this, one of my concerns would be, can you potentially undermine that trust with your patient using these types of enforcements? What are your thoughts on that?
Yeah, I think again obviously it's a little bit complicated, but I
Yeah.
think you sometimes I joke in medicine, hey, even though I'm internists and pediatricians aren't that well paid, I always joke, hey, that's why they pay us the big bucks. That was what we would say, sometimes in the military as well. But you sometimes have to, risk being like temporarily unpopular, to do that. But honestly, my own experience, with, recommending like firearms be removed from a home has been really very, very positive. And I've had, veterans, actually thank me, afterwards saying, Doc, I really appreciate the way you reached out. But one of the things that we try to do with SAFE, Andrew, and you're actually, an exemplar of this, is that doctors actually will have much, much better credibility when talking about firearms if they're at least knowledgeable, and they know the difference between,
Yeah.
a 9 millimeter Beretta and a 38 revolver and and an AR-15 so I think that, it's like a lot of things in life, sort of the more kind of common ground that you can build with your patients. And this is just, nothing to do even directly with firearms, but one of the things that I do like routinely on the wards, when I meet a new patient is, I'll even say, hey, I'm Dr. Winslow, but, just call me Dean, and I always joke with them, hey, it's just a first name, not even a title. And that'll usually get a laugh out of most people. And then I'll say, this is, I try to model this, in front of our interns and residents and medical students and say, hey, tell me a little bit about yourself before we get into all this medical stuff, about your history and all that. And I ask them like, hey, where'd you grow up? Where'd you go to school? And I'll also, love it, and if I ask, say, hey, did you serve in the military? And they, and one of them say, yeah, hey, yeah, I was a door gunner on Huey's in Vietnam. And the fact that, if you can actually understand, what little bit about what their experience must have been, it's like so helpful. So that actually really helps you when you do have, potentially difficult conversations with people. It's the fact that if they don't view you as an adversary, as another, they view you as actually someone, who is a buddy. And that actually, I think that goes a long way. And again, I'm very fortunate. I've very seldom been a patient in my own life, but at least my own experience being a doctor for almost 50 years, I think, that served me well. And I wonder, Kyleanne, what your thoughts would be, kind of on that.
Absolutely. It's the more you invest, the easier it is to have the hard conversations. And I think,
Yeah,
Devin added it into the chat too, right? Like if you start to call things by the wrong names and like then start
yeah,
sounding preachy, right? And
yeah,
I think it's also perfectly acceptable, to Dean, to your point of like, tell me a little bit more about yourself. If someone is a gun owner, gun enthusiast, whatever you want to call it,
yeah,
ask them questions about their guns. Ask them questions
yeah,
about
yeah.
what they do because it shows an interest. It shows that
Mhm,
you judging. It doesn't come up with all of a sudden of like, oh, now you're at risk to like kill yourself and everybody else. It shows like,
mhm,
hey, that's cool. I would like to learn more, right? And
mhm,
I think nobody ever is, or it's very rare. I will not say nobody. It's very rare that someone is upset if you ask them a curious question
mhm,
about
mhm,
things that they care about, but it
mhm,
builds so much rapport so that if a time
mhm,
comes when you have to be able to say, "Hey, I'm concerned about you because of
mhm,
this." It is now coming from a place of someone who is invested in you as a person, not just a number on
mhm.
a chart, right? And that can make all the difference in the world in terms of like how much someone's really willing to engage.
Right on. And I like this will be my little plug-in here. We've got a really good curriculum online. Module 2 specifically looks at firearm basics for anyone that's in healthcare looking to get a basic introduction on firearms so that you can
Mhm,
essentially speak the lingo and build that rapport.
mhm,
But let's see. I've got a few more questions. It's 8:55, so Eastern time. So let's try to get through them. From Susie M, is there training for vets or active duty military about when and how to tell a military colleague in crisis that you'd like to hold on to their firearm until the crisis passes? In my experience, yes, we do have some global trainings, and the trainings do differ by command.
Mhm. Yep.
So where we're stationed.
Like so there's definitely some, I think, training and engagement about how to have these conversations. One thing that putting my policy person hat on here that is also important is understanding the laws of the states that you live in.
Mhm.
Because sometimes just taking guns from somebody and moving them to your house can get you in trouble yourself as well, right? So I would also caveat like there's the yes, there's training in how to have these hard conversations, but also be very careful if you just take people's guns. Just I'm gonna just like anything, right? Like there's a I think there's the I mean, if the moment comes down to the fact that it's between saving someone's life and getting in trouble, take their guns to save their lives. You can sort everything else out later on, right? But also one of the most difficult aspects about anything with gun violence prevention, and I know a few people on this call have heard me talk about this a lot, is that there is such a patchwork of state laws that exist with regards to firearm ownership, firearm transfers, gun
Mhm.
violence restraining orders, waiting periods to purchase guns, safe storage laws, child access protection laws, right? They are this whole patchwork of everything that exists that makes it very difficult to often, and it makes it very difficult for organizations like the DoD and the VA to create standardized
Mhm.
policies because what works in California may be illegal in Texas, right? And what works in Texas may be illegal in California.
Yeah,
So
good point.
that's one thing that is a really hard part of like trying to have these global conversations.
All right. And then I just want to get this third question out of the way from Mark C. Military exchanges, so the PXs, BXs, NEXs throughout the country sell hundreds of thousands of firearms every year. In recent years, many active duty service members and veterans have taken their lives with firearms purchased from these exchanges, often shortly after they are sold. Are there some policies you would suggest the DoD implements within the exchange system to help prevent suicide?
Oh, Mark. You asked this just to try to get it, yeah. So this is something that I've actually thought a lot about going back to time, actually thinking about more intimate partner violence with this question than necessarily suicide, but there's often very, very similar drivers. There have been efforts made to institute waiting periods
Mm.
at exchanges, which one of the things that we do know from the data and the science is that waiting periods work,
Yep.
right? Waiting periods are um, things that are beneficial. Similarly with permit to purchase, at like permit to purchase schemes where you have to show that you are a responsible, competent owner who
Mm.
has passed the background check prior to even going into the store to buy a gun, right? And these things like waiting periods, things like permit to purchase,
Mm.
in addition, that are similar to things like safe storage, they put time and space and they reduce
Mm.
the impulsivity acts with firearms, whether that be suicide or intimate partner violence or even homicide, right? They are something that adds just one more level of
Mm.
safeguard without trampling on any ownership rights at all, right? So I think those the waiting periods and permits to purchase are things that the DoD should engage with, largely because, to Dean's point, as he had talked about earlier before, you often have a population that has above average stress that may have had some acute issue they don't know how to deal with, that's like in and out of deployments, right? Like that, there are, I think, some important unique safeguards that exist. There's also been discussions around mandating, and I don't have a full opinion on this yet, would want to get a lot more information on it, but like mandating the sale of a safe storage device along
Mhm.
with the firearm purchase, right? That these things need to be bought in tandem,
Hmm.
which there is some early evidence that shows that that does reduce suicide risk. I think it also ties very closely to when we've seen like the Saving Our Veterans Lives Act that's in Congress right now that makes it much easier for veterans to get much more effective safe storage devices, right? Not just a cable lock that's handed out, but actually get lock boxes and
Yeah.
biometric things that we know are actually much more effective and also usually much more palatable
Yep.
to want to be able to use. And so that's an area that I think also needs to have a lot more exploration as to like what does it actually mean to bring these these safe storage devices as part of the point of sale.
Yeah.
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 I think,
If there's
oh,
any thoughts on this
One
too.
one thing though, Andrew, that you've heard me talk about a little bit, and unfortunately, it's never going to happen. Though, would be to actually have a doctor like sign off, on basically, is this person safe to own a firearm? And for I've been flying airplanes since I was 13 years old, and still I have to undergo an FAA physical every 2 years just to fly, not even commercial but as essentially a private pilot. And we don't require any of that of guns. And again, I just anecdotally, apparently this person that was killed outside of Mar-a-Lago just a day or two ago had a history of chronic schizophrenia. And the fact that this person was able to legally buy a firearm, is just to me, it's just so sad. And also, just to share a little bit about my own journey, my first wife actually had bipolar disease, and she was able to buy a firearm and used it to kill herself. This is 25 years ago now. And again, that if she'd been required to have sign off by her doctor, there's no way that someone with uncontrolled bipolar disease would have been signed off by a doctor as being okay to purchase a firearm. So yeah.
yeah. Yeah, it's definitely an option with the military,
Hmm.
uh, being that it is in the Constitution, it could produce some challenges for
Yeah.
those not in the
No.
military. But that's something to
Yeah.
consider. Yeah, yeah. All right. Well, it's 9:03 Eastern time. We can stick around and answer a few more questions, but I will just like to thank everybody who's
Mhm.
joined in. I would like to say that we do have an upcoming event. This is going to be April 16th, 8 p.m. Eastern Time, 5 p.m. Pacific Time, focusing on trauma-informed care approaches and the
Mhm.
importance of language we use as healthcare providers when talking about firearms with
Mhm.
patients and in our communities. So, Allison's going to put this in the chat. It's going to be a Zoom meeting link for registration. And we hope we'll see you all there, but we'll stick around and answer some more questions.
Mhm.
Next one, how can someone who is already a doctor or studying to become one get a broad understanding of how to do a better job in communicating with veterans? Are there resources available to us? I'll let you lead that one, Dr. Winslow.